Good morning. So I'll be talking about the typhoid fever relapse from the microbiological aspect. So in identification in our lab, so first, if there is a blood culture bottle positive, we do gram stain to identify if it's a gram negative or gram positive organism, followed by biochemical identification, where we identify which species. Followed by serotyping, we do something called a slide agglutination test. So coming to the resistance profile for Salmonella typhi, as Dr. Akash already mentioned, so if there is a pan susceptible, that means it is susceptible to all the first line antibiotics for Salmonella typhi treatment. That is your ampicillin, potriconazole, and SXT. If there is an MDR case, that means this is resistant to the first line antibiotics with or without resistant to fluoroquinolones. And if it's a fluoroquinolone non-susceptible case, that means it's resistant to the fluoroquinolones. And an XDR case, that is an MDR with addition to the third generation cephalosporins. And there is also something called as ESBL positive. So here it is also resistant to the up to the third generation cephalosporins. So for our patient, we did a phenotypic AST. Based on the phenotypic method, our patient had a fluoroquinolone non-susceptible strain. So this is taken from our department. We have done a study on this. This is an unpublished data. So here we can see there are different types of haploids. These haplotypes are based on the SNPs. That's the single nucleotide polymorphism. So based on the SNPs, we have 1 to 88 numbers are there. Among them, the H58 is the most predominant one. So this, for example, so this H58 MDR strain, that will also have different types of genotypic lineage. Example, in this one, it will have 4.3.1.1, which will carry the plasmid Inc. HI1 that will have resistance to the blood TEM-M1, that is the ampicillin CAT-A for chloramphenicol, DFR-A7, and SAL for the SXT. So different lineages type of H58 will carry different plasmids, and that will code for different antibiotics. So if you see all this H58 MDR and QRDR, these are all seen in our Indian continent. Whereas something called an XDR, this is as of now is only seen in Pakistan. So XDR, as mentioned before, this is resistance to the first line antibiotics, that is the ampicillin, chloramphenicol, SXT, and fluoroquinolones. And additional, there will be resistance to the third generation cephalosporins, which is the BLA SXT M15. So this strain as of now is seen in Pakistan. So if you ask, do we have a resistant strain, third generation resistant strain in India? Yes, we do, but we don't term it as an XDR. We term it as an ESBL positive strain. Now coming to the case reports on relapse. So this is taken from a study published in the Infectious Disease in Journal 2018. So here they are reporting there are typhoid relapse cases are there about 5 to 10%, mostly seen in Malaysia, Pakistan, Vietnam, Taiwan, France, and Denmark. Also in the northeastern state of Malaysia, out of 246 patients, 14 patients, that is 5% of them, had relapse cases. And these relapse symptoms were actually milder than the original episodes. And in Pakistan, about 14% of the children who were treated with the third generation cephalosporins had relapse. And this was confirmed with the bacteriological evidence. So till now in 2018, we didn't have any relapse cases reported from India. But from this paper from 2018, they are reporting 3 relapse cases from Kolkata. Out of 107 hospital admitting typhoid cases within the period of 2 years, they have reported 3 cases. So for typhoid fever relapse, there are 2 types. One is the reinfection and one is the recrudescence. So recrudescence meaning the initial strain and the second strain are the same. So if the initial strain is that also caused the second attack, so that relapse is called recrudescence. Whereas in reinfections, both strains are different. So the second attack in this relapse will, if it's a different strain, we'll term it as a reinfection. So for our patient to determine which type of relapse is, we have done PCR. So PCR using 3 primers. The first primer is to know if it's the paratyphi A, and other one is for the Salmonella typhi, and the other one is for the H58 4.3.1. So for our patients, both the culture we detected it's Salmonella typhi having the H58 lineage. So based on the AST profile and lineage specific PCR, this case is a recrudescence case. So based on the AST pattern, this patient was treated with ceftriaxone, but there were occurrence of relapse. So the relapse can be mostly can be due to the reduced accessibility to the intracellular locations, because salmonella typhi is an intracellular pathogen. So maybe because of the decreased accessibility to the intracellular locations, that can cause the impaired pathogen eradication, which will lead to the relapse. And also it's also favored by a switch in the beta lactam targets. So if there is a production of this PB3 sal, then we have seen in this study that there is a less susceptibility to the ceftriaxone treatment. So for take-home messages, so in India, we have lots of fluoroclone non-susceptible strains are there, more than 99%. And we should treat the patient based on AST report. And there is also an emergence of the ESBL positive S types, around 5%. So for those patients, the drug of choice will be azithromycin. Even though if you use azithromycin, so this azithromycin can actually develop resistant strains if we overuse it because of the drug pressure. So in COVID times, we were actually overusing of the azithromycins. And then we found out when we do the MIC values, there is actually one-fold higher dilution was there. So we can use azithromycin, but it should be cautious. Thank you.
Thank you, Dr. Rosemont. Would you like to add any more comments? Any questions or comments from the audience?
Yes, sir.
Patient already treated with ceftriaxone, not achieving bacterial clearance, so what other antibiotic we use? Just earlier you mentioned 50 days that was information was not given. If the patient is having significant deficit inflammation, the ceftriaxone treated with ceftriaxone again having bacterial, we need to go for targeting. And another question is, if we want to differentiate the recruitment the reinfection, do we need to document microbiological variants? Second,
recrudescence and I will go ahead with second question first. So recrudescence and relapse. So for that, yes, to distinguish either it's a recrudescence or relapse, we need biological evidence, microbiological evidence. So by molecular typing, as Dr. Bismol told, it has to be done by molecular typing. But first question regarding azithromycin, if there is still a QTC prolongation, and we can go ahead with azithromycin, but still questionable. So we can go ahead with.
What is the duration of therapy planned for the patient?
Now 10 to 10 days, 14 days max. You have given ceftriaxone so far. It's we have given for 14 days and azithromycin also 14 days.
The first time he got for
He got for 10 days.
10
He
days.
got the correct dosage. Actually, as per our guidelines, it has to be given for 10 to 14 days. Ceftriaxone 2 gram IV OD or 1 gram BD. So he got the complete course.
Any other comments, questions? If not, thank you everyone for attending. I especially would like to thank the Department of Microbiology for being here, taking their time and presenting to us. Thank you for all the presenters for your presentation, but today's prize will be given to Medicine 5, Dr. Akash.
Took them gloves. Instead of party, I think it's a good idea. We should see how we can encourage more of at least. That means they'll have to be little conscious about their time. So they can make it as it is a lot of so,
Yes.
so thank you for coming. This typhoid survey, is that complete or it's going on? It's ongoing. Thanks. So yeah, we need to see how we use this participation. A lot of learning. I'm glad that that's it.